Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, T cells genetically modified to express an anti-B cell maturation antigen, chimeric antigen receptor, cause remissions of poor prognosis, relapsed multiple myeloma, by Brudno et al. My name is Michael Becker, and I am an Associate Professor of Medicine and Director of the Blood and Marrow Transplant Program at the University of Rochester Medical Center in Rochester, New York, United States. My oncologic specialty is in myeloma, leukemia, and cellular therapy. Multiple myeloma remains an incurable cancer for the overwhelming majority of patients despite recent advances in therapy, including the introduction of antibody therapies directed against CD38 and SLAMF7. The outcome of patients with myeloma refractory to bortezomib and at least one immunomodulatory drug were recently shown in a paper by Kumar et al. To be quite poor, with median event-free and overall survivals of 5 and 9 months respectively, highlighting the need for novel approaches for the treatment of relapse disease. Chimeric antigen receptors utilize the specificity of monoclonal antibodies to redirect the cytotoxic capacity of the patient's own T cells to tumor cells. In CAR T therapy, the patient's T cells are collected by leukapheresis and then transduced with DNA encoding a special receptor that binds to specific protein targets. The modified T cells are then infused into the patient where the tumor serves as an activator for the modified CAR T cells, stimulating their rapid expansion and killing of the cells expressing the target protein. T cells with engineered chimeric antigen receptors against the B-cell antigen CD19 have demonstrated considerable activity in B-cell ALL and in diffuse large B-cell lymphoma, offering hope for this approach in other malignancies, including myeloma. A key factor in the success of CAR T therapy in B-cell ALL and diffuse large B-cell lymphoma is the very limited expression of the CD19 antigen on B cells. B-cell maturation antigen, referred to as BCMA in this podcast, is ubiquitously expressed on the surface of multiple myeloma cells, as well as some normal plasma cells and a small set of normal B cells. BCMA is not expressed on the other normal tissues, including normal hematopoietic stem and progenitor cells. This favorable expression pattern led the authors to develop the first anti-BCMA-CAR T therapy. In this article, Brudno et al. Reports the results of their study of CAR BCMA T therapy in patients with relapsed refractory multiple myeloma. An initial report in Blood in 2016 presented the data on their dose escalation study with limited responses at the lower dose levels. Their current report summarizes the results of 16 patients treated on the highest dose of 9 × 10⁶ CAR BCMA T cells per kilogram. The patients included in this study were heavily pretreated with a median of 9.5 prior lines of therapy, with nearly all having received prior high-dose therapy and stem cell transplant, and the majority having failed a second autologous stem cell transplant. 63% of patients had multiple myeloma refractory to the last treatment regimen before protocol enrollment, and 40% of the evaluable patients on the highest dose level had high-risk cytogenetics, including 33% with deletion 17p. BCMA expression of myeloma cells was required for study enrollment. Peripheral blood mononuclear cells were collected from patients by leukapheresis followed by culture with IL-2 and anti-CD3. Cells were transduced by the MSGV gamma retroviral vector containing a murine anti-BCMA single-chain variable fragment, hinged in transmembrane regions from the human CD8 alpha, the CD28 co-stimulatory domain, and the CD3 zeta T cell activation domain. CAR BCMA T cells were dosed at 9 × 10⁶ CAR expressing CD3 positive cells per kilogram of patient's body weight after a conditioning regimen of cyclophosphamide and fludarabine. Despite their advanced disease, 13 of 16 patients achieved a partial response or better, with 11 of the 16 patients achieving a VGR strict CR. The median event-free survival for the Phase 2 cohort was 31 weeks. 6 patients treated at the highest dose level have ongoing remissions at the time of the submission. Minimal residual disease assessments are being increasingly utilized to assess responses in patients following therapy for multiple myeloma. Following CAR BCMA T therapy, 11 of 11 evaluated patients were found to be MRD negative by bone marrow flow cytometry. 5 patients were not evaluated for MRD due to lack of response, MRD negative bone marrow prior to protocol enrollment, or patient noncompliance. Circulating BCMA-CAR T cell levels peaked between 7 to 14 days after infusion and continuously declined up to 2 months post-infusion, with peak BCMA-CAR T cell levels of patients who responded to treatment higher than the levels in non-responders. The cellular therapy community's experience with CAR T therapy is growing quickly, and toxicity is a major concern. Similar to the experience with CAR CD19 T cell therapy, CAR BCMA T cell toxicity was substantial and appears to be related to the degree of bone marrow involvement by the disease. The first 2 patients treated at a dose of 9 × 10⁶ CAR BCMA T cells per kilogram had extensive marrow involvement prior to therapy and experienced severe cytokine release syndrome (CRS) toxicities. Subsequent patients were required to have less than 30% marrow involvement prior to proceeding with CAR BCMA T cell. Greater than a third of patients treated at the final dose required vasopressor support, and 1 patient required mechanical ventilation. With increasing experience, diagnosis and grading and treatment of CRS and neurotoxicity have become more standardized. In this report, 5 patients, 31%, received tocilizumab, and 4 patients, 25%, received corticosteroids for treatment of toxicities. BCMA-CAR T-related neurologic toxicity was limited to confusion or delirium in the setting of CRS, except for a single patient who developed encephalopathy. As with other CAR T therapies, cytopenias were also common, typically occurring after the preparative regimen, but 2 patients developed delayed onset pancytopenia, day 28 and day 25 after CAR BCMA T cell infusion, requiring growth factor support and steroids. Mechanisms of resistance are important considerations in the optimization of therapies. Preliminary data from this cohort of patients suggest 2 potential mechanisms that warrant further exploration. CAR T levels following infusion have been associated with clinical outcomes. Data from a subset of patients identified T cell senescence as a limiting factor in T cell expansion. Understanding and optimizing the T cell repertoire being employed, as well as enhancing in vivo CAR T cell proliferation and survival, are important areas for further research. Another pathway to resistance is loss of the target antigen expression on the cancer cells. This has been demonstrated in ALL and diffuse large B-cell lymphoma. At the time of progression, loss of surface antigen expression of BCMA was demonstrated in 1 patient following CAR BCMA T cell therapy. Current research to identify alternate targets for CAR T therapy in myeloma is ongoing to potentially mitigate this effect. In summary, this is an exciting report of the application of CAR T cell therapy for patients with multiple myeloma. CAR BCMA T cell therapy was associated with deep and sustained responses in a subset of patients who were heavily pretreated. The report highlights issues associated with CAR T cell therapy and offers future avenues for research to optimize responses and limit toxicities. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.